All right. Welcome to Catalyst for Healing. I'm Maria Lloyd, licensed therapist, and I'm here with Dr. Yanuck.
Hi.
And we're doing it kind of a fun little series to interview each of us so that you can get to know us a little bit better. So I am going to take the opportunity today to interview you so I probably will learn a lot about you today too, because
I bet there's some stuff that you don't know.
Yeah, I'm sure. So anyway, it has been such a privilege to work with Justin. I call him Justin. Sorry, Dr. Yanuck.
It's totally fine. I tell my patients that too. I know I'm a doctor.
Okay.
Yeah,
I know
okay.
I'm a doctor.
Yeah.
But anyway, we just met about a year ago, but I would love to hear a little bit about your story in terms of maybe something about growing up, and then how did you get into medicine? Where did you go to school?
Cool. Yeah. So I grew up in Southern California. I don't think science was really on my mind too much. Like when I went into undergrad, I was a political science major, which I guess is a type of science,
Okay.
But it wasn't like a STEM
That's
science.
Interesting. I didn't know that.
And I loved it.
And you went to UC Davis.
I went
We
to UC
did find
Davis.
out we both went to UC Davis. Shout out.
Only Aggies are allowed on this podcast. So yeah, I went in as a poli-sci. My sister, who's 4 years older than me, went into med school, and I think probably planted the seed for me that like this is like a pretty cool career. And I remember talking to her a lot and hearing about her stories in med school and like cadaver lab and like, holy, you get to like work in human bodies. It's so crazy. And quickly everything shifted when I went to, I was like trying to figure out what I wanted to do in poli-sci. And then I don't even remember how it came up, but there was something with a primate lab. One of the largest primate labs in all of North America is at UC Davis.
I can believe that. I wasn't there.
If I'm being honest, being now vegetarian 4 years, it still pains me that I was like a part of this institution. I understand this is how research is done, but I have so many issues with it in retrospect. But it's also like so much of what we understand about the human body and medicines comes from these types of places. Right. So at least it's important for me to have experience in it. So I went to this primate lab, and one of the projects that I started to work on was trying to find an animal model for autism. And so they were taking rhesus macaques, which share an enormous amount of the same DNA as us, like 99% or something like that. And they were lysing a part of the amygdala and trying to basically create some sort of animal model for autism. And working in that lab, seeing the MRIs and in the field cages, I don't know, some seed was planted like, this is definitely what I want to do. In hindsight, it's like so obvious that I should have been a psychologist. Like I loved like seeing the interactions and the dynamics between the monkeys and the social structures and things like that. So I switched my majors to, it was neurobiology.
Interesting.
And I did like a focus on like computational neurobiology. I loved all the classes that I did there. I was an avid rower. I was on the ski team. And so my time in college was wonderful. And I didn't meet Dr. Richter there. We met in med school at UC Irvine. And at UCI, I couldn't decide what I wanted to do. I thought I kind of liked everything. So I kind of just fell into emergency medicine because it turns out in emergency medicine, you kind of have to do everything. They say we're the second best at everything, right? Like we have to know how to deliver babies. We have to know how to treat old people and young people, but we're not maybe as good as the pediatrician that would be at all those things. And then kind of fast forward, did my pain fellowship.
Yeah. So how did you decide on that?
I did emergency medicine residency at UCI, and I love emergency medicine. I'm still an ER doctor, but there was, in that time, and I mean, it still continues now, 2016 to 2019, we were really in the opioid epidemic. And I was constantly seeing these patients coming into the ER with opioid overdoses or with kind of manifestations of chronic pain on opioids and the things that would happen to those patients. And I was just like frustrated with the way that we were treating those patients. I was frustrated with the lack of knowledge in terms of how to treat pain in the ER. It just felt like very reactive of like just hit them with opioid. And then if patients got really bad pain, you can send them home with a small dose of opioids and that's okay. And I was seeing the literature that showed it didn't take much to set someone off on the wrong path. The pendulum then swung really far where we were so scared to send anyone home on opioids. And then we were like judging people's pain as if it was valid or not. And so all these things were kind of manifesting that, plus, you know, my father, unfortunately, having some chronic pain issues and seeing kind of the care that he was getting. And so I did this pain fellowship, which was very non-traditional from emergency medicine. There's probably I'd say less than 50 of us that have done this through ER. And I was the first at Mass General that did it. And the idea behind pain medicine is you learn how to treat pain, right? It's like every part of pain. And so my favorite rotations weren't necessarily the interventional things like, oh, spinal cord stimulators and pumps and all these things. Like some people love that. I spent a month with a pain psychologist and I was like, this is fascinating that whatever this guy is doing is probably more effective than the stuff I'm doing in the operating room, you know? And so I think that probably was like the initial seed that was planted for me of like, maybe there's another way to treat pain and all these other things that we're dealing with. We should talk more about that guy in the future. Such an interesting person. And like his theories he had about pain were incredible. And so, yeah, I came back and I had a private pain practice. I joined a private pain practice and I worked with some providers, and yeah, it just like it wasn't for me. That space, I didn't get to really spend time with my patients. I felt like there was a pretty significant subset of patients that I wasn't able to help. And yeah,
when we were talking once, you said you started to realize how many, I mean, obviously there's a lot of comorbidity with mental health issues, but how many weren't getting better because that part wasn't getting treated.
Totally. Yeah. I mean, it just like, I would see 25, 30 patients a day. And it was just like,
wow.
At least half the time I felt like I was seeing the same patient, like the same stories, people on disability or people that have lost their jobs or people that were, you know, going through crises at home, that they were having the kind of somatic manifestations of those things, which was pain. And they were coming to me for control of that pain because I was the person that I was kind of the end of the road. People would see their surgeons and their primary care doctors, and then they would shuttle them to me. And so I was managing their pain the best I knew how, which was trying to, okay, your knee hurts. Let me see if I can numb your knee. Your back hurts. Let me see if I can numb your back, right? So like put it really simply, right? That's what epidurals are and knee injections and things like that. And I would do these things and then they would still have pain, or it would only last for a couple of weeks and then it would come back. And I was like, this is just like, I'm not trying to malign the profession. Like obviously I still believe deeply that interventional pain management works. I just felt like there were some people it really worked for, but there was also an equal amount of people that it really didn't work for. And that's where my mind just kept spiraling of like, how am I not able to help these people?
Right.
And the whole medical model is not designed to really give you the opportunity to help those people, right? Like when you're working in a medical practice, like you have to take care of patients in the way that you can also keep your practice afloat. Does that make sense? Like if you're reading between the lines, like it's not that we are offering things that aren't helpful for the patients, but if I spend 30 minutes with the patient and discuss with them the importance of getting out in nature and hiking and therapy, I don't make any money from that. Right. And it's really hard because it's like, I got into this profession because I want to help people, but all of the incentives are structured to like, if you want to have a viable practice in our insanely complicated, terrible medical model, you have to do the things that can also support your practice. And so like when those are aligned, where I have tools like an epidural that I know can help someone, and then I have someone with back pain that's got sciatica, like, I'm going to do that versus maybe having the 30-minute conversation about, you know, stretching exercises and the importance of sleep and hygiene, right? Like it's just, that's the reality of it.
So you felt limited.
Felt super limited. And like, I think, I don't know how that changes, to be honest. And so I had to get out of it. Was really what it was for me. And like, this is not me trying to cast judgment on the profession. Again, I just want to be really clear. Like like they really help a lot of people. And I think a lot of people get pushed to the sidelines with chronic pain, especially because they're really difficult patients to treat because rarely do we get the satisfactory, we fixed you. Right. And I think primary care doctors don't like to deal with that. Surgeons surely don't like to deal with that, because
Right.
once the image looks pretty, well, they can't make it look prettier, right?
Yeah.
And so then it's like, we'll go to the pain doctor.
Well,
So
what percentage were autoimmune illness? Because I feel like a lot of autoimmune illness is chronic pain
yeah,
symptoms.
that's a whole other thing. But yes, I don't know percentage, but it was a lot.
Yeah.
Like we had,
Yeah.
rheumatoid arthritis, Ehlers-Danlos was a lot of patients.
Okay.
I mean, all of it.
Because not in a black and white sense, but they're showing more and more, that working mentally and healing trauma can help with autoimmune illness.
Yeah. I just felt like stuck in the space I was in.
Yeah.
And I wanted to find a way to help people in the way that I felt I could best help them.
Mm-hmm.
And so in end of 2021, I quit that pain practice.
Mm-hmm.
I was working in the ER, to support myself and my wife. And then I was also doing some clinical research.
She was expecting a baby, by the way.
Yes. Yeah. Expecting
So
a baby.
excited.
Yeah.
Mm-hmm.
It is really exciting. May 8th.
May 8th.
Yeah.
And it's a little girl.
Little girl. We're very excited about that. Still doesn't kind of seem real, but I'm sure as you get closer, it'll feel very real. So yeah, I was kind of in a weird space where I was like trying to figure out what can I do to like do the things I want to do. And actually, right before Tanya and I connected about ketamine clinics, I got really interested in psychedelics from a personal perspective, like researching it, reading books on it.
Uh-huh.
I had a couple patients with fibromyalgia that I was able to help with ketamine in the pain clinic, and I was like, this works way different than anything else.
Yeah.
And so I think the seeds were planted for me to do something different and bigger. And then I just needed someone like Tanya, Dr. Dahl, my partner, who has kind of like the administrative organizational talents
She's
to like
amazing.
get stuff done.
Yeah.
And we kind of partnered and started this space where like I get to spend the time with the patients. I get to give them my pain reprogramming tools that I think are customized for them that can help them.
Yeah.
I get to guide them down the track of, getting better with ketamine, which I think can be really effective medicine for some people. And I really get to know them. And I get to know their families sometimes, and I get to meet their dogs. And it's just
really gets to know them.
Yeah.
You're so personable. I mean, the clients that we share, they're always like, Justin's, he's on the phone with me and he follows up with me. So, I mean, people really appreciate that.
Yeah. And I love it. I really do. And I think, I don't know. I just feel like I just don't want to do work anymore that like doesn't feel like it's a reflection of who I am and what I want to be. Yeah. At the end of the day. And so like it was nice to be able to create my own space. Yeah. Yeah. So this is still new. You're still working at the ER. Yeah. Still working at the ER. I still do. The first clinic in San Juan was about a year ago that you started? 2 years ago. Yeah. Oh, 2 years ago. December 2022. Oh, that's right. Yeah. Because I met you right before and you did the 1 year party. That's when we opened our clinic and it was crickets. Yeah. I remember we were like, it was so much work to get everything set up. Yeah. And then we're like, okay, we did it. And then it was like, we have no patience. And I can imagine starting a business. Like the eternal struggle of like trying to be really intentional about how we grow this space. But at the same time, like, making sure that we have the right people that come in. We've learned so much about this in this space. And I think I've also learned over time to be cautious with how attached I get to patients, if that makes sense. Like, I really care about patients' outcomes. Right. But there's also like, I can only control the product that I deliver, right? And make sure that I think they're a candidate. But like, I can't control the outcome. And I think it's really critical to start with like, this doesn't work for everyone. Yeah. Obviously. Yeah. Right. Nothing works for everyone. But I think. But what percentage do you feel like it does? I mean, we know the research says 80%. Like, I genuinely, I don't think it's 80. Okay. Yeah. I don't think it's 80. I think it's probably somewhere between 60 and 80. Okay. And I think there's so many variables that go into that. For the people that it doesn't work for, a lot of times it's like there's variables at home that aren't optimized that I think, okay, how do we optimize those variables? Like, let's say like an acute life stressor or they got sick, or
Yeah.
you know, some other medication change that happened at the same time that wasn't intentional or something like that.
Right.
Like maybe had we tried it a different way or a different time, possibly could have been
Mm-hmm.
different, or maybe with a little bit more therapy up front could have been different.
Yeah.
I don't know.
But that was one of the things
Yeah.
when we met, we were both passionate about integrating it and doing it the right way with
Totally.
the therapist.
Yeah.
And so your clinic has really, you know, required people to do therapy as part of the
Mhm.
process. And you're also adding Spravato
Mhm.
to your practice. Do you want to
Yeah.
explain a little bit about the decision?
Yeah, I mean, I think it was when we first started the clinic, like one of the things that I hated the most about working in a private practice was dealing with prior authorizations for insurance.
Yeah.
It is absolutely insane that we have a medical model where the doctor determines something that could be beneficial for the patient, and the patient
Yeah.
needs the help. And then I have to ask an insurance company who is purely incentivized by profits,
right?
To determine, is the thing that I want to do for the patient worth doing.
Yeah. And to keep in mind that you have to try and fail 2 antidepressants to qualify. And then it takes, 4 to 6 weeks to get the authorization.
Totally. So are you talking about Spravato now?
Yeah.
Yeah. Okay. So yeah, maybe I should get off my soapbox here. Because also, as the caveat to that, as I described maybe 20 minutes ago, there is also a perverse incentive in the medical space to maybe do more things for patients than would be indicated, because that's how revenue comes in.
Yeah.
And like I have, you know, I've heard about that and seen it. And so it's something, you know, I think it's important to call it out too, right? Doctors are not perfect. We try and be really intentional about the things that we do at Renew, but it's a balance for sure.
Yeah.
So anyway, Spravato, basically the beauty of Spravato is it's covered by insurance, period. And so it allows us, for patients that cannot afford the intravenous ketamine, which is a lot, right? It's expensive.
Yeah.
It's out of pocket. The insurance is not going to cover it. It allows us to offer it to those patients.
Yeah.
And like, there's not clear evidence that shows one is more effective than the other. And so who am I to stand firm that, because I think IV is more effective, I'm only going to offer that. So yeah, it seemed obvious to us. The second we made the decision, it was like, why did we not do this sooner?
Yeah.
But it's been a process to get credentialed with insurances and figure out how the whole authorization process. And so it's something that we're starting this new year, like 2025.
Yeah.
We'll be offering to patients. And I think what I'm most excited about is like taking everything we've learned from the IV ketamine space, which we'll continue to do, and not changing a thing, but just doing intranasal versus IV.
The only difference is the protocols are different.
Sure. Yeah. They'll be in the clinic, for a fixed amount of time, typically.
Yeah.
There's like a vital sign check at a certain predefined period of time, like 40 minutes in. But otherwise, like, we're still going to be doing the one patient, we're still going to be recommending psychotherapy strongly.
Yeah.
We're still going to be having kind of the post-treatment integration that we do with them.
Yeah.
And I think being intentional about all those is going to be really important. And if it's covered by insurance, like, it just makes it so much more accessible to people.
Help so many more people.
Yeah. Because it sucks. It really sucks. I'm sure you see this as a therapist, where you're like,
people really need it and they can't afford it. Yeah.
Yeah, it's painful. Like, I hate that part of this job.
Yep.
Yeah.
So anyway, we're excited to see where your clinics go. So right now you have one in San Juan Capistrano.
Yeah.
And then you open one in Irvine.
Tustin, yeah.
Tustin.
And
then
Seal Beach.
Dr. Richter runs the Seal Beach one.
So yeah, we have they're all 3 small clinics.
Yeah.
But we really care about what we're doing.
You care about it, I know.
Yeah, really deeply.
That's what I love.
So yeah, and it's lovely getting to work with people like you.
Yeah.
And the therapists that have come on to kind of be part of our referral network are also incredible.
Yeah. I know, it's great because they have a whole network, and so depending on you kind of know at this point what we specialize with and what we work well with. So you send us clients that are a good fit.
It's really interesting that I feel like that's something I actually really only came to understand through this process is how it's not even just your guys' different skills, from a therapy standpoint. Yeah,
totally.
It really is. Yeah. And so that's an important thing for when I work with the patient to try and understand who do I think would resonate the best with them.
Yeah.
And I feel like some of my questions are more guided towards who do I think is going to be the best therapist for them rather than maybe what's going to be for the ketamine,
Right.
Because it's so important.
I know.
My gosh. It's so obvious when the patients that do therapy and the ones that don't, it's so much more effective.
Yeah. And having the good fit therapist, like
Yeah.
you just said,
Totally.
makes all the difference.
100%.
The
100%.
success. But all
So,
right,
yeah.
well, I'm glad we got to get to know you a little bit more
And I got to, I
today.
guess, complain about our current medical establishment.
Well,
But
you have a balanced perspective about it. I mean, it's like, again,
Yeah.
there's limitations to it, but there's some things that it works really well for, and it's just trying to understand that balance, right?
It is. It totally is.
Yeah.
And so it is what it is. This is where we're at now, and I'm really happy with what we've created, and I'm really happy with where I'm at in my career right now, which is cool.
Awesome. Awesome. Well, thank you for joining us, and we will see you next week at Catalyst for Healing.
Bye.
Bye.